So moving on to advanced life support. So in our next slide, we're going to see a video of us where we've got a patient back. So we've got return of spontaneous circulation. So we've got ROSC, our patient's generating its pulse. It's not breathing for itself, so we're still ventilating it. And we are monitoring very closely. So a lot of the times we will get patients who will get ROSC, but then will rearrest again. And this video is a really good example of that. So our patient, we've got it back, it's got a pulse, it's got, PQRS complex for every pulse generated, but we notice the end tidal is coming down, our pulse quality is coming down, and it's a really good example. So we stop chest compressions and there we go, starting again. And you can see that 2 thumb-handed approach there. And with our breaths. So yeah, just a really good sort of like idea of our sort of crash scenario here. I think if I wanted to critique that, we could do more closed loop communication in that, about what drugs we're giving and things like that. So, and we'll talk about debriefing and things like that, but that's always something to work on. And I think, again, we were very lucky to have a lot of people there available, but just showing that, crashes can be controlled and done in a non-emergency way. Everyone has a job that they're doing, very focused, but it was very clear in that video that we could obviously see our patient was trending downwards and we were giving drug therapies, and Helen, who was running the crash, asked one of the members of the team to start chest compressions. So in that instance, you probably should have said, I'm starting chest compressions, but that's an example of closed loop communication. So advanced life support. So as soon as we pop a capnograph, ECG, gain IV access, administering drug therapies and defib our patient, this is all advanced life support. So really important in our patients that we do grab our little capnograph as soon as we've got that airway secured. And again, close communication, have we applied the capnography? I'm applying capnography, it's switched on. And again, same with ECG pads. So on this slide, we're going to give a little breakdown of our patient. Our patient's arrested. We started a 2-minute cycle of basic life support. So our chest compressions, ventilation. And once we've done our 2 minutes, we're going to stop and look at our ECG. So with our patient, we've obviously applied our ECG. We've got all the bells and whistles on. We've got somebody feeling for a pulse. And we're like, is there a pulse? What's our end tidal C2 doing? So to achieve, we want to aim for an end tidal C2 of 18 and over. And if we've achieved ROSC, this will suddenly jump up really high. So high for our patient who's arresting. So obviously a normal end tidal CO2 is like 35 to 45. We're not going to get that in these patients. So at a push, it is hard. You have to put a lot of effort in, but 18 millimeters of mercury. And if it suddenly jumps to say like 20, 25, or 25, we know we've got return of spontaneous circulation. So again, these patients probably aren't going to be breathing for themselves, so we will still have to be ventilating, but just to bear in mind, we really want to aim for 18, and if we notice there is a jump, then we have got ROSC, and maybe we can then, but if we haven't, we've got to continue our chest compression. So again, is there a pulse? Is there a shockable rhythm? And you have to decide as a team whether you think this rhythm's shockable or non-shockable. So non-shockable rhythms, we're looking at pulseless electrical activity, so that's PEA or asystole. And if we have got a non-shockable rhythm, we're then going to start obviously we're not going to defibrillate this patient, so we can decide whether we're going to give a drug therapy. So, or we talked about Obviously changes in recover guidelines. So one of the changes is giving atropine, which we'll talk about later on the slide, but giving atropine once and not doing it every other cycle with your adrenaline. So giving it probably sooner rather than later, your atropine, especially if they've had a vasovagal event. And they found the half-life shorter, so we're only going to give it once, and the whole time we're doing CPR in this patient, and then we'll continue the epinephrine every other cycle. But say you've noticed that, yeah, we've checked, is there a pulse? What's the rhythm? Is it a shockable rhythm or non-shockable rhythm? If it has got PEA or asystole, we're then going to think about drug therapy, whether that is atropine or using our adrenaline. So obviously atropine, that's going to help with our cardiac sort of contractions, whereas epinephrine, that's more of like a vasoconstrictor, bringing our blood where we want it to go. And that's every other cycle. And again, so we're going to then start a 2-minute basic life support, chest compressions, ventilation again. Okay. And if we have got a shockable rhythm, that's looking for ventricular tachycardia, pulseless, and ventricular tachycardia or ventricular fibrillation. And with the pulseless ventricular tachycardia, that rate has to be over 200. And ventricular fibrillation, obviously your myocardial cells are just like shooting off. It looks really ugly and all over the place. And obviously if you're not your stop chest compressions, you know that ugly rhythm is ventricular fibrillation because you're not jiggling your patient all around. So once we notice we have got a shockable rhythm, we're going to continue chest compressions while we charge our defibrillator up. And again, not everywhere has a defibrillator. You can do precordial thumps. This is really, again, it may or may not be effective. I'd say definitely your defibrillator is going to be more effective than a precordial thump. But again, it's worth looking at the evidence on the recover guidelines that they put out and seeing what you think. But again, that could be done instead of your defibrillation. But again, it may not change the shockable rhythm. So once we've decided we've charged up our defibrillator, we've selected the appropriate kilojoule setting, we've put gel on our pads, basically turn our patient into on their backs and apply our defibrillator pads, shout clear, and then give our shock. And then once we've let go of our patient, we're going to start chest compressions again. If our patient's refractory to defibrillation, you can think of other drug therapy. So we'll later talk about lidocaine, amiodarone, and things like esmolol as well. So also included in our advanced life support, as we said sort of earlier, capnography. So this basically helps us quantify how good our chest compressions are, how well we are doing our effective chest compressions. And again, we're feeling pulse quality at the same time, but again, this is a very crude way of measuring it where we actually get a number. And again, you can, I tend to look at the end tidal as I'm doing my chest compressions sometimes to help me gauge. And again, I put on here 15 millimeters of mercury, but the recover guidelines and the new guideline states 18. So ideally 18. But again, your patient, depending on what's going on with them, if they've got cardiac disease and things like that, it could be it's 15 millimeters of mercury. But again, if we go below that, we're doing poor chest compressions, and we need to think about how we rectify that, swapping in somebody else to do chest compressions. Perhaps this person's, very tired, they've already done 2 minutes and we need to swap, and we should have swapped in the 2-minute pause. And again, we're always going to check a 2-minute, after the 2-minute cycle of basic life support, whether a patient has got a pulse, have we achieved ROSC, what's their end tidal CO2 doing, and again, it's going to jump up, it's going to be 20 and over if we have achieved ROSC in these patients. And again, it's good to monitor it. Again, you'll notice the end tidal will start to trend down, your pulse quality will start to trend down if you have stopped chest compressions, if you have achieved ROSC, and you may have to initiate chest compressions again. So again, with that advanced life support, we're going to pop our ECG in our patients. Again, we need to know if they're in a shockable, non-shockable rhythm. Make sure our pads are secure. So we tend to use ECG pads that you stick on like to people, but we pop those on in our sort of canine feline patients on their pads, and make sure we've taped those on. The clips may not be as secure, especially if your patient's moving around. But again, making sure whatever ECG you're using is secure on your patient. And once we've done our basic life support, chest compressions, ventilation, we're going to pause and stop and look at our ECG. We're going to be feeling, is there a pulse for every complex that's going on there? Is there? Perhaps there isn't, perhaps there is. Is it in a shockable, non-shockable rhythm? So it's the guide for the next intervention of like whether we, defibrillate or not, or do we continue with chest compressions, ventilation and our drug therapies. And again, we're still going to give epinephrine every other cycle, even if they are in a shockable rhythm as well. So as well as ECG capnography, we're looking at IV access. So hopefully your patient has got an IV in, but again, if they've just rocked up, like a dead on arrival sort of situation, you may have to think about maybe doing a cut down. So where your cut down is basically, it's easier to do this in a hind limb, looking at your lateral saphenous most likely, clipping it up. And obviously we're continuing chest compressions, ventilation while we're trying to get this IV access in. And I think cut downs basically will prep the skin as much as you can, quickly, briefly, using a scalpel, expose the vein, so move the sort of skin and the tissues away, exposing the vein. You can see it, visualize it, placing some forceps underneath this vessel. So obviously you have somebody holding the limb and those forceps for you, and then you'll be catheterizing that vein directly into it, and you'll suture that into the vein. This can be quite tricky and quite a delicate job during CPR, but IV access is better over say other, like even intraosseous. So it is preferred, but again, very tricky to do, and maybe think about getting intraosseous access in the meantime while you're trying to get IV access. So we're very lucky here. We have an easy IO where we basically have a drill. We drill into our patients at sites where we would place intraosseous catheters, as you can see on the picture and the background there, and it should be placed if IV attempts are unsuccessful. So if you spent over 2 minutes trying to get IV access and you can't, placing intraosseous catheter is recommended. If we don't have access to an intraosseous catheter, like a drill, it can be very hard putting a handheld like intraosseous catheter into like a big dog or something. So having a drill makes it easier. And again, some people have like bone marrow biopsy drills, which is the same sort of drill you can use, but you would need different needles and catheters and things. You can do it via the ET tube. So you would give sort of like double to 10 times the dose of the drug and down your ET tube. So you basically place a dog urinary catheter down the ET tube, try and get this drug into like the bronchioles and be absorbed that way. Giving that drug via the catheter down the ET tube, giving it a good amount of saline. So whether you flush that with like 5 to 10 mils, depending on the size of your dog, and some large breaths as well. And again, as we said, IV is superior to IO. These are the drugs that you can give via the ET tube. So naval is quite a good one to remember. So we're not going to give sodium bicarb via our ET tube, and that's like something to remember. But yes, this can be quite tricky, but we have an easy IO and it really does make a difference. That's a little picture of it there, top of our crash trolley. But yeah, if you're lucky enough, it makes it a lot easier. And we want to think about like what our patients had previously. So whether they've had opioids a few hours ago or sedation, even if they're in the new recommendation, the new guidelines, they recommend reversing any sedation that they've had, even if it was like 6 hours ago. So still administer reversal agents if they have had some sedation early in the day, or opioids, and hopefully that may or not work for your patient. But other drugs to think about. So we obviously talked briefly about in our little chart there, our graph about going through our 2-minute basic life support and non-shockable shock rhythms and drug therapies. And I mentioned obviously giving atropine only once. So yeah, new update. We're not doing it every other cycle. It's got a longer half-life than we thought. So we only going to give it once, and earlier is recommended if there is a vagal arrest. So if we've got a patient who we suspect has had a sort of vagal arrest, we would then probably reach for the atropine sooner rather than later. And to mention with the epinephrine, the adrenaline, so high dose adrenaline has been taken out of the guidelines. So there was shown to be a reduced survival to discharge with the data, and in human medicine as well, they don't have high dose adrenaline either. They've taken theirs out too. So that's something to think about. But again, we're going to give that every other 2-minute cycle. So we're going to give it every like 4 minutes, and that's going to be low dose only. Okay. And again, the I suppose the superior drug of vasopressin is all still on the algorithm in the new guidelines as well. Again, it's the same thing as same drug, works in the same way as adrenaline, but it works better in an acidic environment. So epinephrine maybe doesn't do as well in an acidic environment. Obviously, our patient's arrested, so they're very acidic. They have got very high lactates. We're perfusing them by compressing their chest. So they're very acidic, and the environment's going to be very acidic. So a vasopressin maybe would work more efficiently. This is very hard to get hold of, even in other countries, in the States. Even Dr. Fletcher, who wrote the part of the Recover Guidelines, has said how difficult this is to get hold of. So again, the outcome has shown no different in giving vasopressin and epinephrine. So again, epinephrine is absolutely fine, but it has been removed again from human medicine, the human CPR. And I think maybe we're always looking at changing our guidelines, so it may change in the next few years, but vasopressin is still on there. But again, don't feel like you're not doing the best for your patient because you're not giving vasopressin. It is very hard to get hold of. And other drug therapies you want to think about. So these drugs we were giving to a patient who's refractory to defibrillation. So amiodarone, more preferably in cats than lidocaine. But again, if our defibrillations work, this is sort of a last attempt of making sure we can sort of help those myocardial cells sort of behave themselves, as we say. And esmolol is a new drug that's been added, so it might help reverse the beta effects of the epinephrine. That's the thought process behind it. But again, these are, if your patient's sort of refractory to defibrillation and these drug therapies, it's not looking grand for your patient. And again, sodium bicarb. So we'd only give sodium bicarb if we've been doing CPR for over 15 minutes, and obviously not via the ET tube, and if their pH is below 7. So this is a video of defibrillation, which is quite a nice one. So it shows us doing chest compressions, and then charging our defibrillator, popping the patient on their back, defibrillating, and then going back into chest compressions. So yeah, cardiac pump, then we're on our back, we've got the defib ready, shine clear, we've defibbed, and then we're straight back into chest compressions. So that's quite a nice video. So the goal is basically we want to with a defib, we're going to check if our patient's in a shockable or non-shockable rhythm, where we're looking at the 2-minute pause at ECG. If we are in a shockable rhythm, we're going to continue chest compressions, charge up our defibrillator and get ready to use it. And once we're charged, and then carry on our chest compressions once we've emitted that charge once we've defibrillated our patient. I say get a gel buddy, because it can be quite scary doing the defibrillation all by yourself, and obviously you're part of a team. Gel buddy is not a assigned role on recovery guidelines, but it's quite nice to have somebody there to be like, hey, don't forget the gel. So if you are a person that's just there in the background, you can be like, I can be your gel buddy. And making sure our patients roll to the back, supporting your patient with your paddles. You're going to hold that patient over each side of the chest, and you don't want to be touching that patient at all. You want to be touching the table, no one touching the table, no one touching that patient, and shouting clear. And we're going to shock our patient and then continue the ventilation and compressions as well. So in the new update, they used to say doubling a dose. In the older guidelines, you double it each time, whereas the new update, we just double the dose of energy if it's not worked the first time, and you just stay at that double dose. So you just double the dose once, and that's it, and that's the rate through, that's the energy level throughout CPR. And our goals of defibrillating our patients. So I think everyone thinks, oh my gosh, you're going to zap it back to life, but actually what we want to do is basically stop any electrical activity within those ventricles. We want to be like, oh, give those myocardial cells a shock and be like, stop the ugly rhythm, stop it. And then basically, hopefully with the aim, we want to resynchronize those myocardial cells. So if our myocardial cells, they're all healthy and our patients may be healthy, they might not be if they've gone to a cardiac arrest, we are more likely to sort of have it be effective and stop all that we depolarize those myocardial cells, and we give them a chance them to sort of maybe behave themselves and get back into a more of a normal rhythm. The longer they're in this ugly rhythm of, say, pulseless VTAC or ventricular fibrillation, there's going to be more ischemic injury, so less perfusion getting to those cells, and they're less likely to be depolarized, and it's less likely that we're going to be successful in our defibrillation of these patients. So something to bear in mind, that a goal is basically just to shock those myocardial cells, get them to sort of behave themselves, and maybe get back to doing the jobs they're meant to be doing. But again, the longer they're in that, those ugly arrhythmias and shock rhythms, there's more ischemic injury in these patients. So it's just a nice little table here. I think make it a bit clearer, but so obviously for our non-shockable rhythms, that's asystole or pulseless electrical activity. We're going to continue our sort of basic life support, so our chest compressions, ventilation. We're still going to give things like epinephrine every other 2-minute cycle, so let's say every 4 minutes, and maybe think about giving atropine, that's giving it once, and that is going to be earlier on. And with our shockable rhythms, it's going to be pulseless VTAC, so the heart rate's over 100, 200, or ventricular fibrillation. We're going to continue basic life support while we're charging our defibrillator. We're going to put it on our patient, hold our patient, making sure everyone's standing clear, and then we're going to shock our patient, and we're going to continue those chest compressions and ventilation. If we're still refractory, we're going to be thinking about lidocaine therapy or amiodarone. Again, reaching for esmolol if we're still refractory. We've got open chest CPR. So again, this little pitch, this little person in the background. Sorry if it's a distressing image, but I think it's very rare that everybody gets to see open chest CPR. And I think if you're already, patient's already under anaesthetic and you're in theatre, it can be quite easy for cardiac massage to occur, going through the diaphragm and giving cardiac massage. You're already scrubbed in, the patient's already got an IV, it's intubated, maybe being ventilated already, and you can get in there and do cardiac massage. This may be considered in large breed dogs, so I'd say like the mountain dogs, like they're very big and very hard to get a cardiac output on through just chest compressions alone. And those are the cases where you may think, oh, I've got this really big Bernese Mounted Dog or Mountain Dog, St. Bernard Mounted Dog, and I want to think, you know, they're not doing very well. Do we have to get consent for open chest CPR rather than closed? Is that going to give us a better outcome? And what other ailments our patient has as well? That's all taken into account. So it's not a benign thing to, like, you know, crack a chest and yeah, they're saved. It also comes with, you know, for the welfare of this animal, we have sort of to think as a whole, like patients with a systemic disease, we probably we're not gonna maybe consider if they've got neoplasia or something like that. I think it depends on the circumstance and the situation of that patient, and I think that's the importance of having a discussion about being prepared and ready for those patients that will go into us and may need open chest CPR. Again, part of your sort of kit, we are really lucky to have a little kit in our crash toilet. It's got you know, rib retractors, sterile gloves, scalpel, you know, suturing kit and things like that. Again, these patients will need chest drain. They'll have obviously rib fractures and they'll have myocardial contusions as well. So to bear in mind for like post-op CPR care that they may be slightly different as well. So in patients that, you know, don't have any sort of monitoring on them, this is not for in-clinic setting. So mouth snout I'll talk about because it's in the recover guidelines, and you know, for, like, say, bystander CPR, they would call it in human medicine. You know, like, you're going to do 30 chest compressions to 2 breaths. And again, if you're worried about, you know, disease and stuff, you shouldn't, you know, be perhaps doing like breaths in the patient. Again, only for non-intubated patients and out of the hospital setting. If they're in clinics that, you know, we're going to intubate the patient and we're going to apply sort of our life support to them, but it's there for you to read about and recover guidelines as you wish.